Hi, everyone. Apologies for the delay. We were having a little bit of technical difficulties, but I think we are good to go now. So we appreciate your patience. I'll go quickly with this quick intro. Dr. David Kaye will be presenting tonight on cervical disc herniation. Please feel free to enter your questions at the Q&A box at the bottom of your screen, and Dr. Kaye will take as much time at the end to answer as many as possible. We will be recording this presentation, so we will send it out at the end as well. Dr. Kaye, you can take it from here. Thank you,
Okay,
everyone.
great. Thanks everyone for coming tonight. Sorry about that. 3 years after the pandemic and I'm still having problems with my Zoom, so that's fun. So tonight's talk is going to be called Under Pressure, the Truth About Cervical Disc Herniations. And my goal is really to try to both explain the condition generally, but more importantly, explain when the condition may be a problem. Because as we'll see in the talk, it's pretty common. Disc herniations are pretty common. Whether you have symptoms from that are not so common. And so, with an eye towards that, let's get it going. So, this is kind of our game plan for the night. We'll discuss, some introduction. What is a disc herniation? What are the types of disc herniations? What type of symptoms may you have from those? How do they normally go? Do people do well? Do people do poorly? And then what are some treatment options if you end up with a symptomatic disc herniation? So how big of a problem is this? So disc herniations in the neck are definitely less common than in the lower back, but generally pretty common. So the incidence, meaning the rate of an adult in the United States having a neck herniation, is about 5 to 20 per 1,000 people. So that's, upwards of 2% a year. That's symptomatic, meaning there may be a higher prevalence of people with asymptomatic disc herniations, but at least that you come in with neck and arm pain, somewhere between 0.5% and 2%. It's more common in younger people. As you get older, you actually lose the water content of the disc. So a herniation becomes less likely, but spinal stenosis, which we'll discuss, which is just narrowing of the nerves on the spine, actually becomes a little bit more frequent. It's debatable whether it's more common in men or women, but generally we say it may be a bit more common in females than males, but pretty equal. And the most common levels are generally at the lower cervical or neck levels. And the reason for that is most of your motion actually happens, not most, but a lot of the motion at the fulcrum of the spine happens at those lower levels. So seeing an isolated disc herniation at C5-6 or C6-7 is actually pretty common if you're just going to see a single level. Let's go through some definitions. So what is spinal stenosis? So what stenosis is, there are two images on the right side. The upper one is a normal one. I'm going to go through what an MRI looks like so that people get a better sense of what that is. But the bottom, I think you get a sense. I'm not sure if you can see my arrow, but there's some narrowing around the spinal cord and the nerves as opposed to seeing that nice fluid. So all stenosis means, and patients ask all the time, it just means narrowing. And that narrowing can be on the spinal cord, it could be on nerves. And how that manifests is you start having symptoms. And those symptoms are obviously most commonly neck pain, but the more concerning symptoms are when you start getting arm pain, weakness, maybe some altered sensations, things we call paresthesias, which means people describe bugs crawling on them, lightning, weird sensory things, which aren't normal in day-to-day life. And that's either from compression on the nerves themselves or even on the spinal cord. Sometimes you get stenosis not from a disc, but from overgrowth of some of the other bones in the spine. I try to give the analogy, if you have hip arthritis or knee arthritis, you get those maybe bony or knobby knees, but other than knee pain, nothing else really happens. The problem is when you get the overgrowth in the neck or lower back, as the bone spurs form, which is a normal part of arthritis, they start growing into structures, and those structures in the neck end up being the nerves and the spinal cord. So what types of stenosis are there? It's really broken down into two types. There's foraminal stenosis or central stenosis. And if you ever looked at an MRI, maybe a report that you got from a radiologist, you'll see these terms. And it seems like jargon, but they're important. They're important for us clinically, and they generally represent different things. So starting with, let's call central stenosis on the right side of the screen. So central stenosis means that the center of the spinal canal, where the spinal cord lives, is getting narrowed. And sometimes it gets so narrow that the spinal cord itself gets compressed. Alternatively, foraminal stenosis is no longer dealing with the center of the spine, but it deals with the nerves. That's what we refer to as a pinched nerve. That's in the setting of something called foraminal stenosis. The difference is if your nerves are compressed, you may end up with arm pain, numbness, tingling, weakness, as opposed to when the spinal cord itself gets compressed, where you end up with something called cervical myelopathy, which essentially is spinal cord dysfunction, and that represents, balance issues, dexterity issues. You could still have the pain and numbness and tingling, but you start getting some more diffuse kind of global dysfunction. I think this is helpful. The screen on the left is the exact same screen or image on the right. The left is a cartoon depiction. The right is an actual MRI. And I thought it might be helpful just to go through that briefly to talk about some of the anatomic structures and what you may see. So honestly, it's upside down. When I go through these in the office, it's usually the other way. But what you're seeing here on the right side, I hope you can see my arrow. This is the bone in front, or the disc. So we call that the annulus and the nucleus. That's kind of the cervical disc. Immediately behind the disc is the spinal canal. That spinal canal has the spinal cord, and that's surrounded by fluid. There should be nice, healthy fluid around that allows the spinal cord to move. And then the nerves come off the spinal cord, and the neck, they kind of point forward and come out the front. And there should be two tunnels on either side. Those are the neural foramen. That's where the spinal nerves live. And then all the way in the back, you have the lamina, or the facets, and those are the posterior elements, or the bone in the back of the neck. So the picture I was showing you can see here this disc herniation, which is starting to push on the spinal cord and nerve. It's hard to see it here, but you see this bright signal right here. That's a disc herniation. So who's predisposed to a disc herniation? So in fact, there are actually some risk factors. People usually say, like, I didn't get in a car accident, I didn't fall, I just woke up one morning and my arm was sleeping or screaming in pain. And undoubtedly, that's the most common way I see it. People say they went to bed one night feeling perfectly fine, they woke up in the morning and they just chopped my arm off. But things like injuries, falling off a ladder, car accidents certainly predisposes you to that if you have a bad enough injury. There are actually some occupational hazards. So several studies have showed that lots of vibrations, truck drivers, jackhammers, can actually predispose you to disc herniations. And then interestingly, environmental factors like smoking, you decrease the blood supply, which starts causing some micro damage to the discs. The discs have very poor blood supply. So you take a poor blood supply and make it worse, you're predisposed there as well. So a little plug to stop smoking for everyone. So how does it present? So I think this is one of the more important slides that I'm going to show tonight. A disc problem or a disc herniation does not necessarily mean neck pain. Back in the early 90s, several studies were performed looking at, if we take the general population, totally healthy, normal adults, how many of them are actually going to have, disc bulges, herniations, stenosis? And so, up to 40, you'll still see 20 to 30% of people with asymptomatic radiographic findings at 40 years old. By the time you get to 60, it's closer to 60%. And by the time you're 80, basically 100% of people will have some sort of MRI finding that's concerning for some stenosis. Now, of course, we're not seeing 100% of people who are coming to the office with either needing surgery or even having symptoms that we think are consistent with that. So just because you have neck pain doesn't mean it's from your disc herniation. There's a lot of reasons, including muscular things, facet issues, fascial issues. So it's not, the algorithm there or the calculus is not exactly linear. The good news is neck pain is almost always effectively treated without surgery. It might take time, it might take some effort, it might take some frustration, but easily 50 to 60% of people are going to get better with non-operative things like physical therapy, non-steroidal anti-inflammatories, Aleve, Advil, Motrin, Celebrex, and then even injections sometimes. Alternatively, a pinched nerve or cervical radiculopathy presents differently. So, I'm sure, I don't know if people have been to the different offices, but when you see a spine surgeon, they'll always ask you, are you having arm pain? Are you having leg pain? If I give you a pencil, could you draw down your arm in a very specific way where you're feeling the pain? The reason why we're so annoying about that is because the nerves really have a very, very classic and typical pattern or distribution. So the image on the right is called the dermatomal map. So they're called dermatomes, which means that each nerve in the neck reliably, there's some crossover, but reliably goes down the arm in the same way each time. So as a spine surgeon, what I'm looking for is I'm looking for somebody to tell me that they have arm symptoms in a very specific distribution that matches what I'm going to see on their MRI, right? Because it doesn't do me any good for someone to have, or it doesn't do anyone any good for someone to have arm pain with an MRI that's completely inconsistent with what we're seeing. There's usually a different diagnosis. But when things line up, we're usually much more effective with our treatments. So the symptoms include pain, weakness, like we talked about, numbness and tingling. Neck pain is pretty common even in that setting. I don't know how many people have ever experienced something like this, but sometimes when people have arm pain, it helps me distinguish whether this is like a shoulder issue or a neck issue. Shoulder issues hurt when you move your arm. So if you were to lift your arm above head and you have a shoulder issue, it hurts. Interestingly, nerve pain hurts when the nerve is on maximum stretch. And a nerve is on maximum stretch when point A to B is as long as possible. So if you were to lift your arm above head or maybe bend your arm, you've shortened that distance that the nerve has to travel. And so you actually get relief of symptoms. So that's called the shoulder abduction relief sign. That's usually very pathognomonic or really kind of tells us that you probably have a pinched nerve going here that we need to treat. And to that point, when people present with things like radiculopathy, it is so common that there are, kind of either a mixed picture or sometimes a misdiagnosis. So at Rothman, we obviously have spine, but we have shoulder surgeons and hand surgeons. And so there's always close collaboration when someone presents like this, because sometimes it's just carpal tunnel, or sometimes it's a frozen shoulder or a rotator cuff tear. And a lot of those will overlap. Their symptoms really kind of masquerade as other symptoms. On exam, we want to kind of test your strength. We want to test your sensation. We test the reflexes. And then we start doing some annoying things where we're trying to almost elicit the pain. All those things can help us determine, A, are you having nerve pain, and B, can we reproduce it? So up until now, I've largely been talking about radiculopathy or nerve pain, which is like from a pinched nerve. I want to briefly talk about myelopathy because I do think they present differently and they're treated differently. So the common symptoms with myelopathy, people will say, hey, my handwriting just got really bad. Things are constantly falling out of my hands. I feel like I'm drunk when I'm walking. All those things start alerting us that maybe there's something more than just a pinched nerve. You definitely can have arm pain in that setting, but a lot of times there's painless. People say, like, I cannot believe this is my neck. I really have no arm pain at all. So we can identify some of that on exam. We'll have people, do heel to toe walking, repetitive tasks, and then we'll test your reflexes and weakness. And then there are some kind of unique tests that will be positive in that setting. Today, maybe not super important to go through those, but there are some things that your physician may do in the course of a physical exam that might seem strange, but are all trying to alert us to potential spinal cord dysfunction. So you come in, you have neck pain, you have arm symptoms. So what do we do? So ideally, at some point, you'll need an MRI because we really can only do so much with an X-ray. It's good to know you have no fracture. It's good to know the alignment is maintained. But we really need to know, can we match what you're telling us in the office to what we're seeing on an MRI? When we can do that, we're usually much more effective at giving you a good treatment. Things like EMGs, I'm a little bit on the fence about that. EMGs really don't often dictate management, but they can be helpful. An EMG is probably best, in my opinion, at identifying things other than neck issues. What I mean by that is you could have a totally normal EMG in up to 40% of cases of neck and arm issues and still truly have an easily diagnosed and easily treated pinched nerve or spinal cord pressure. So I use it most, I would say, when I'm a little bit suspicious that what you're experiencing, the numbness and tingling, maybe come from somewhere else. Maybe it's carpal tunnel, maybe it's cubital tunnel, meaning issues in the arm itself. I think there it actually is quite helpful because if we can spare someone an unnecessary surgery on the neck because it turned out it was from their hand, I think that's good practice. We spoke about some things that we see on imaging. So x-rays, like I said, not super helpful, but you can see changes in alignment. You can see, do you have something called congenital stenosis? Is the neck narrower on average than maybe the rest of the population? MRI, of course, is the best. And we're looking at areas of compression. We're looking at potentially changes in the spinal cord architecture itself. I'm not sure if you can see my arrow, but this sign down here, that little white spot you see in the spinal cord, that's called myelomalacia, which is a mouthful, but it basically means some element of spinal cord death. That's a serious issue, but obviously something we can pick up on MRI. All right, so how do people do? So I think the best thing to know, and I try to tell everyone this early on because it's miserable. You come in with nerve pain, you feel like, hey, I will do absolutely anything to get out of this pain. The good news is really greater than 70% of patients do respond to a course of non-operative care, including physical therapy, anti-inflammatories, really over the first 6 weeks. Now, a lot of patients fall out of that time zone and they go on to need other things, potentially injections, potentially even surgery. But really, the majority of patients will respond. What about myelopathy, right? So that's a little bit different than a pinched nerve. So when the spinal cord is compressed, that's usually a surgical problem because spinal cord compression generally goes one way. Usually, your symptoms may be mild, but it's generally not going to regress or go back to normal. You'll probably just stay like that. We call it a stepwise progression of disease. So you live like that for 1, 2, 5 years, and then something happens. Maybe you take a fall, maybe there's an accident, maybe nothing. And now you're at a new plateau and you're there moving forward. And we can't always get you back to the higher step. So when we see that, we try to catch it earlier rather than later. The outcomes are excellent if caught early, but are even good when you catch them late. There's a big group in Canada that's been doing a lot of the research for the spine group, looking at outcomes, surgical and non-surgical in this setting. And even patients with mild disease do great, but even patients with severe disease do as well. So we try to catch something like that earlier rather than later. I do want to briefly talk about treatments and our expected outcomes. So again, pinched nerve, at the very least, I think we owe it to ourselves to give it a good go at non-surgical care. That includes physical therapy, acupuncture, non-operative modalities, anti-inflammatories, potentially even injections. I think the reasons to maybe circumvent that and maybe go a little bit quicker to surgery might be things like very progressive. I'm sorry, very significant weakness or just completely intractable pain, like pain that really like you can't live through. Those things might force our hand, but generally we try to be conservative. Myelopathy, like I said, spinal cord dysfunction, we're a little bit more aggressive with, admittedly. Now, there are certainly a large cohort or a large group of patients that will come in with what I think is severe spinal stenosis with absolutely no symptoms. I think those are interesting cases because, at least in my practice, I think it's totally appropriate to watch those types of cases and just make sure that there's no sort of changes over time. So, those are patients that I'll generally follow maybe on a biannual or annual basis. And then there are the patients who have kind of, the less significant findings on MRI, but very dense symptoms. And that's another discussion we have. Do we try to catch this early versus late? Okay, so let's say your surgeon tells you, he thinks you need surgery. So surgery comes in a few flavors, and I'd like to briefly go through them just to give people some context when they walk into the office. So this can be done posteriorly or from the back of the neck, or this can be done anteriorly through the front of the neck, or a combination of both. And let's briefly go through those. So when we talk about posterior or back of neck surgery, generally, not always, but generally, that's from multi-level disease. So somebody who may have like their entire neck just has spinal stenosis, congenital, environmental, for whatever reason. The good thing is there are both fusion and non-fusion options. Not everyone who needs a posterior, or meaning back of neck surgery, needs to be fused. There are certain criteria that will allow motion preservation for. I do think it's generally a bigger surgery. I will tell you, while I think at a year or even at 6 months, I think people do great. I think there's more pain up front, admittedly. And I tell that to everyone when I have to do a posterior surgery. My preference is anteriorly based surgery. I think it's just a relatively painless approach. We don't really have to cut any of the muscles. I think you can address the discs directly. We really go right after the disc. And I think the recovery is quite nice for people. So, what I tell people is maybe less pain from the front. Definitely, you're trading off the pain for maybe some swallowing issues, which should be temporary. It really should be, you're talking about 93, 95 or percent or greater relief of arm greater than neck pain. But people generally do very well. Several studies have looked at like, well, what are some of the most successful medical procedures in surgery? So hip replacement's definitely up there, appendectomy definitely up there, but an ACDF, an anterior cervical fusion, is up there also. So we're very happy when that's an option for patients. The goals are relief of pain. Again, that comes at the cost of a fusion. So by definition, we're trying to eliminate motion. This is just a very quick schematic. I don't want anyone passing out if we're showing like true blood. So this is just how it goes. We go to the front of the neck. It's a muscle sparing approach. We cut out the disc. It's called an annulotomy. We eventually will pull that disc off the spinal cord and nerves. And then we replace it with some sort of spacer. And nowadays, you could either be bone, it could be plastic, it could be titanium. That's a little bit dealer's choice. And then we secure it with a plate. Every study performed really since like 1970 shows that anterior instrumentation with a plate has better outcomes. So that's pretty much standard of care nowadays. Okay, I do want to touch on replacement versus fusion. So everything up until now is a fusion. And in fact, the operations are identical. The difference is at the end of the case, are we locking up motion or are we allowing motion? The thought is, and this is not settled science, but there's a debate among spine surgeons in the medical literature. If we operate on someone's neck and by design stop motion at that level, what is the likelihood that the compensatory motion, meaning the motion that the neck is trying to achieve above or below that level, will predispose someone to having worsening of arthritis? Now, that is not settled science. The answer to that question is still unknown, even 50 years later. But at least it's a reasonable thought that, if you have excessive motion above or below, are you predisposed to arthritis? And if you were predisposed to arthritis, might you need another surgery? I think that's a fair question. The benefit of a replacement is that it maintains your motion. Now, I do need to talk about, well, what are the outcomes and really who's a candidate? And I'll go through that in a second. But just so you know, because people are like, oh, I really want a replacement or I really want a fusion. The operations are identical up until you put in the implant. So the materials, right? Bone, we showed that, or plastic and titanium, versus for a disc replacement, largely titanium and plastic, sometimes a ceramic. By design, a fusion, you will lose motion. And for a disc replacement, the goal is to maintain motion. The good thing is right now we have about 15 years of data for disc replacements and 50 plus years of data for cervical fusions, both with absolutely excellent outcomes. So if you're pushed one way or another by a surgeon for good reason, and I'll explain that in a second, I think you should feel completely comfortable with either approach. The reoperation rate is probably a little bit higher with a fusion because you need to get it to fuse. And there's some portion of people, maybe 5 to 10%, who may not fuse. Their biology may not just accept it, and they would need another surgery. Well, with a replacement, we're not looking for that fusion, so it's probably a bit lower. This is just a case we did maybe about 2 weeks ago of a 2-level disc replacement. You can see excellent motion. Okay, but who's a candidate, right? Everyone comes in asking for one. And as your advocate, I really have to give proper advice. So to have surgery in general, you got to have radiculopathy or myelopathy. I think that's clear. And you'd want to have failed some course of non-operative management. We don't like to just jump into surgery. Ideally, at least for a replacement, the FDA has only approved up to 2 levels of disease. So if you had 3 levels, you could have a hybrid, meaning you could have like a disc replacement at one level and a fusion at another. but you couldn't have 3 discs, at least by the FDA approval. I know on Instagram and different places you may see images of 3-level disc replacements. That's technically not FDA approved. I don't have a problem with it. Physicians should use their own judgment, but technically the FDA approval is for 2 levels. I think the absolutely most important thing is you really have to have relative preservation of your cartilage. I mean, you should not be someone with a very arthritic neck getting a disc replacement. I try to give the analogy, I'm sure people have heard of knee replacements. So you can have a total knee replacement or a partial knee replacement. A total knee replacement is when both compartments or all 3 compartments of the knee, the inside, the outside, and the kneecap, all have arthritis. I think a total knee replacement is an excellent option. If I were to tell you, hey, I know you have 3-compartment disease, but I only want to replace part of it, you might like that. You might want a more minimally invasive procedure and spare that, but long term, you're going to fail because you're still going to have the arthritis at the other parts of the knee. So the same thing in the spine. We're only replacing the discs. So if you have arthritis at the joints in the back of the spine, chances are you might not do as well as you otherwise could have if I allow you to move through that arthritis. And ideally, we do want you to preserve range of motion. I can't give you more motion with the disc replacement. We can just maintain what you have. All right, so I want to wrap it up, and then of course I'll open it up for questions. But the important things are cervical stenosis. Stenosis simply means narrowing, and that can manifest as a pinched nerve or spinal cord compression. For neck pain alone, we almost always will recommend conservative care with very few exceptions. When non-operative management of that type of arm symptoms fail, I think there are excellent anterior and posterior options, meaning from the front or back, and it really does depend on your specific case. The good thing about neck surgery, not that back surgery isn't successful, but neck surgery is almost uniformly excellent. So if that's what you need, I think you will ultimately be happy with the outcome. And now I will open it up for any questions.
Thanks, Dr. Kaye. Can you hear me?
I can. Should I
Okay.
unshare my screen maybe?
Sure. All right, perfect. All right, we have some questions, and I see several are coming in. So I'll start at the top. I did put in the chat if we will answer as many as possible, and if it's really, really specific to your case, it may not be able to be answered. I mean, I'll ask the question, Dr. K, but I know some things, are a little too specific and may require, a consultation. Okay, so I'll start at the top here. I have had ICDF surgery and fusion at C3, 4, and C4, 5. This is a little specific, but we'll see if you can answer. And was warned of potential problems right above and below because of the fusion. What should I keep an eye out for?
So I think that's a great question. Without getting specifically into those levels, that's a little bit what I was alluding to with the whole field of disc replacement. Again, it's not settled science. Just because you've had a fusion does not necessarily mean you will ever have any issue at the other levels in the future, but you may. And the things to look out for, I mean, neck pain, unfortunately, is pretty common. So I wouldn't say, oh, if you're having neck pain, you're having an issue. I think radiating arm pain is less common. I think if you started developing persistence of numbness, tingling, or radiating arm pain, that's when I'd be a little bit more concerned. And I think in the setting of someone who's had surgery, if you were to start developing those symptoms, I think it's reasonable to just check in and get a consult to make sure that things are going the way you want them to be going.
Thank you. Next question. Could you please detail double crush syndrome and treatment plan? Example, cubicle tunnel and cervical radiculopathy.
Right, another really good question. So that slide I was showing where you saw cervical radiculopathy in the middle, but all those branch points of the overlapping or masquerading symptoms, so I was saying you might have one or the other. What double crush means is not only do you have one, but you also have the other. So you actually have 2 phenomena going on. So in this case, it was cubital tunnel and cervical disc or cervical radiculopathy. So unfortunately for double crush, a lot of times you end up needing to treat both issues. Generally, there's where an EMG actually could be helpful because sometimes the EMG will pick up that you have very severe carpal tunnel, let's say, and they look at the neck and they're like, yeah, you have pressure there, but it's not so bad. There, we'll usually say, listen, try the carpal tunnel. That's like a 5-minute procedure. See how you do. If you do great, then you may not need a second surgery. Sometimes we see spinal cord compression that looks really bad, and we're like, listen, we know you have carpal tunnel, but you got to address this neck first, then you may not need the carpal tunnel. So it is definitely patient specific, but the phenomenon of double crush is relatively common.
Thank you. This person said they previously had surgery with cervical decompression and fusion about 5 years ago. It was cervical myelopathy, and the surgery involved from C3 to T1. And the last several months, they've been experiencing severe numbness on their right hand and arm. The surgery was done posterior. Any suggestions on what to do?
I think it's worth an eval. So the good thing is once you're fused, you're usually spoken for. What I mean by that is a C3 to T1 has covered the majority of the neck, but not all of the neck. So there's still a C2, 3 level, and then sometimes, rarely, you'll see something at T1-2. So what I would say is if you're having new or worsening symptoms, it could be from the neck. It could be from the level above or below. It could be something else though. Sometimes shoulder issues, elbow issues, hand issues. So again, that's something it's pretty specific. I would probably just say, get it evaluated either with a spine surgeon or, a generalist and see, next best step from there.
Thank you. Another question about numbness. Is numbness in the left hand and fingers, excluding the pinky, likely due to compression of C8, or could it be could it be carpal tunnel?
Okay, so that's a good question. So that, without speaking specifically to your case, the C8 nerve overlaps with the ulnar nerve. Okay, so people who have ulnar neuropathy can look very similar to a C8 radiculopathy. They both generally have numbness and tingling in the small or pinky and ring finger, so probably not C8 in this case. And then there are some findings, kind of the inside of the forearm generally is present for C8 stuff, but not usually for cubital tunnel. And then there are some muscular tests we do in the office. So that actually needs to be teased out a little bit better. But the overlap between carpal tunnel and C8 is a little bit more clear because carpal tunnel will be, your thumb, index, and middle finger, not your ring or small, as opposed to the other, which would be kind of ring and small finger.
Thank you. How many times can a patient have injections in their neck to alleviate pain?
It's another really good question. So my feeling is, and what I tell my own patients is, if you're willing to have injections, I'm there for it all day. Meaning, if people are comfortable getting injections, assuming that they're appropriate, right? So for spinal cord compression, we generally won't do injections because you don't want to necessarily take a tight space and make it tighter. But let's say you're an appropriate candidate. We've decided, yep, this is totally appropriate for injections. Personally, I'd be okay with as many as you want. The problem is the insurance companies in 2025 are not as nice as we are. And so they, a lot of times, will have guidelines about how frequently that can be performed a year. I personally don't do injections. We have a whole group at Rothman that does that. I think generally they tell people approximately 3 times a year.
Thank you. This person said connection to migraines, question mark, assuming neck pain, a connection to migraines.
So I think 10 or 15 years ago, you would have 100% told people that neck issues don't cause migraines. And that's still pretty much our philosophy. About 2 or 3 years ago at the Cervical Spine Research Society, when they were in New York, so it must have been about 3 years ago, someone presented a case series of about 50 patients who were presenting with primarily headaches and neck issues, and they had neck surgery. And a large portion, I want to say like greater than 60%, had relief of headache symptoms. In my own practice, the way I like basically what I tell people is if you have an issue that I think needs surgery and you happen to also have headaches, I wouldn't have the surgery with the expectation of headache relief, although that frequently happens. But that shouldn't be the goal. Meaning, if your only symptom is a headache, I think you just have to wait into surgery carefully whether that's actually going to improve or not.
Thank you. Can there be a combination of stenosis and myelopathy? And what is the treatment for that, if so?
Um, I'm going to try. I hope I understand the question. So, myelopathy can only happen in the setting of stenosis, right? So you can only have spinal cord dysfunction if there's already pressure or stenosis in the neck. So yes, I would say that they're always hand in hand. The treatment, like I said, generally, especially if you're symptomatic, is generally surgery, and that can be performed in a number of ways. But that, one goes hand in hand with the other.
Okay, thank you. This person said they had anterior cervical discectomy, C4 to C6 fusion in 2014. Doing well. They were told that the surgery would last 6 years. It's 11 years and they're doing fine. What is the likelihood that they will need a further surgery?
So congratulations. So if you look at the rates of what's called adjacent segment disease, meaning what is the likelihood that over time you will need further intervention having had surgery, it's about 2.5% per year. So over 10 years, we say, you have about a 15 to 20% risk of something else. Now, that means 80% of the time nothing happens. And you've fallen right into that cohort of patients who have these surgeries and do fantastic without the need for further surgery.
Thank you. Sorry, I'm just going through these. Is is anterior surgery acceptable if you had prior anterior neck surgery?
Another excellent question. So I will tell you, revisions end up being a large part of Rothman practice. We see, things from the community or other surgeons, and a lot of times they've had prior anterior surgery. I will not hesitate to go back in. I mean, you have to be careful during your exposure. You don't want to, you're going through scar. That is true, but it's completely safe and acceptable.
Thank you. Is a burning neck pain more indicative of a herniation, stenosis, or radiculopathy? This person said they have a history of cervical and thoracic herniations in 2007, but none since until recently.
Yeah, it's a really tough question to answer. The quality of people's pain, aching, burning, numbness, when it's neck dominant symptoms, is admittedly very challenging to accurately diagnose, like where it's coming from, what the pathology is. Because, like I said, the majority of people as you age will have some sort of change, a disc herniation, stenosis, arthritis, something. And so it makes it really challenging to, honestly look at somebody and say, hey, this burning pain, this is from the disc at C3-4 or something like that. So I know that's a frustrating answer, but that's the true answer. Diagnosing neck pain is very challenging.
Thank you. Can you detail nerve block injections versus nerve ablation injections?
Yes. Again, not my specialty, meaning I do surgery, but I actually don't do injections. What a nerve block is, at least in the neck, well, in the lower back also. So either it's called a transforaminal epidural steroid injection or a selective nerve root block. Let's say you're trying to distinguish which level you think the pain is coming from, and we're not really sure, right? Because you could just get what's called an interlaminar injection, which I consider more of like a shotgun approach, where you do an epidural that kind of bathes all the spinal nerves. When you do a selective nerve root block, you're targeting only one of those nerves. Let's call it the C6 nerve, and you want to see whether, if you inject that nerve, is the pain resolved. An ablation is a procedure where you're actually burning a sensory nerve. It is not a nerve that's functional. It doesn't go down your arm. It doesn't give you any sensation in your arms. It doesn't give you any motor strength. It's a branch off a small nerve coming out of the neck that gives sensation to the facet joints or the joints in the back of the spine. And the theory is that if you can block that or eliminate that as a pain generator, that will improve neck pain. So a selective nerve root block is really to address arm symptoms. A radiofrequency ablation is really to address neck symptoms.
Thank you. I think this is maybe two questions in one, but this person said, can a disc herniation heal once the nerves calm down? And
Uh,
then,
yeah.
okay, I'll let you answer that first.
Yes, let me answer that first. So absolutely. So the disc won't go back into place. So once it's herniated, it's not like the disc then migrates and finds its way to kind of sneak back into place. Your body does not like having a disc herniation. It recognizes it like a virus, and cells called macrophages, which are kind of these scavenger cells, will come and start attacking the disc as if it's a virus. So let's say, for example, I see a patient in the office, I'll call it January 1st, 2025. And they have a disc herniation and they have a terrible arm and neck pain. I say do some therapy, we get them a shot, whatever, and they're doing fine. And then 3 months later, they come back, or call it now June of that year, and they say, "Oh, I have this terrible pain and all their same symptoms. I need surgery." I say, "Okay, what have you done?" They've done a few shots, therapy. I'm like, "Okay, so this is appropriate for surgery." I will always get a new MRI for them 6 months later because I've had in my own practice cases where I thought about scheduling someone for surgery. I get the MRI and the disc is gone, which is a bad position to be in, because that means you have a chronically painful nerve where the nerve pain is still there, but there's nothing you can do surgically to fix that. So the short answer is the nerve can definitely recover and the disc can definitely resolve.
Okay, thank you. And the second part to that question is, what is a calcification at the site of the herniation, and does that require surgery if symptoms persist?
So the calcification can be from numerous places. I assume what you're referring to is that when the disc herniates over time, if it's left there chronically, it can calcify. The collagen itself will calcify, and then it becomes more of a bone spur. Again, it doesn't necessarily need surgery unless it's symptomatic, but if it's symptomatic, we treat it the same way as any stenosis, where we're trying these non-operative things. But if it doesn't work, yeah, a lot of times they do go into surgery, but not necessarily because it's a bone spur, more so because it's a pathology that doesn't seem to be resolving with the non-operative options.
Thank you. There's a few questions about fusions. So this one says, can you address fusion recovery and success rate?
Okay, so fusion comes in two flavors, remember, from the front and the back. I will tell you from the back, I actually tell patients it's one of the hardest recoveries I think they have to do in spine surgery. It is a painful procedure. It is necessary in a handful of cases. And so, if that's what you've been recommended, I don't think surgeons are looking necessarily to jump to do those because the recovery is more challenging. Technically, it's a pretty straightforward and simple procedure, but it's a hard recovery. From the front, there's not a whole lot. Meaning, I've operated even some of my partners who have gone back to work the next day. These are not painful surgeries. The biggest thing I see after that surgery is, swallowing issues, sometimes some hoarseness, meaning the front of the neck issues more so than pain.
Thank you. What is the typical approach to confirmed significant cervical myelopathy via MRI with minimal to no symptoms indicative of myelopathy? Do any studies show improvement with physical therapy?
Okay, so that's a great question. That's what I was saying. So in my personal practice, now this is not, again, you ask 10 spine surgeons for an opinion on a case, you're going to get 11 answers. So this is just my personal practice. So there are two times where even patients with what we're referring to as myelopathy, I will treat non-operatively. And those times are patients with severe stenosis that are absolutely asymptomatic, right? So meaning their cord is compressed. It's clear to me that it's compressed. I'm not saying myelomalacia, so there's no damage of the spinal cord, but there's definitely compression, but zero symptoms. No numbness. I can't identify anything on exam. Their balance is fine. Their dexterity is fine. I generally will watch those patients and just see them back, every 6 months, every year, because most of the time those patients are fine. And if they know, right, I've told them, listen, you start developing any of those symptoms, make sure you come in. And sometimes they'll come in and then they do need surgery. That's one end of the extreme. The other end of the extreme are patients with relatively mild MRI findings, but with very severe symptoms. Those patients generally want surgery. But again, I consider those like two sides of the same coin.
Okay, thank you. So there's a ton of questions. I'm trying to go through them and get as many
It's
answered
nice
as
to have
possible.
you as the moderator to read all these questions.
Let's see. Okay, and this is on obviously this presentation was on cervical, but this person's asking, they said they have pinched nerves on L4 and L5. They don't have pain in shoulders or their neck, but they do have neuropathy in their left foot for over a year. Um, your focus was on neck and shoulders, but what about pain in your feet and ankles due to pinched nerves in the lumbar spine?
I mean, it's really the same algorithm. So I don't know with certainty where that's coming from, but assuming it's coming from the back, it's really the same approach. Meaning neck and arm symptoms and back and leg symptoms are really treated identically. Um, So I would say that persistence of symptoms, having failed an appropriate course of non-operative management, sometimes do respond to surgery. You just got to be careful that you've had an appropriate workup because frequently patients who have true leg and feet pain, numbness, tingling, it turns out to be diabetic neuropathy or something like that, which is of course not amenable to surgery. So it really depends on the unique case, but generally the take home from this talk is that the same algorithm that we use for neck and arm symptoms, we would be using for lower back and leg symptoms.
Thank you. How long after ICDF 1 level do you expect your patients to be on pain medication, and how long to expect swallowing, uh, difficult swallowing?
So the swallowing thing can be real, meaning, even, I tell everyone, every single patient I do that surgery on, I tell them, hey, you should expect some swallowing things. I would say the majority of patients, that's gone after the first few days, but everyone usually has something, it can be very mild. But I even personally have had patients who have symptoms, upwards of 3 months. If it became like a really persistent issue, I would send them to an ear, nose, and throat doctor. But I wouldn't be alarmed if you were having swallowing things even at 3 months. Of course, depending on the severity, depending on the unique case, but that itself is actually not that unusual.
Thank you. I assume this question is coming from a physical therapist. So they ask, what are your thoughts on the McKenzie method, and what should we tell patients with disc herniation to start feeling worse after the initial PT evaluation?
So I'm all about McKenzie, so much so that sometimes, as much as I love physical therapy, it can sometimes be a financial burden on patients. And so I'll have them go on YouTube, kind of, find 10 videos to do and do it 15 or 20 minutes a day. So I'm all about that. I think neutral alignment, kind of flexion, rotation, I think is important. Um, you asked what if they get worse after therapy, right?
What if the pain is worse after the initial PT evaluation?
Now, can you
What's
say
to
that again?
tell? I'm sorry. Can you hear me?
Yeah.
Okay. What to after that first initial PT evaluation, if pain gets worse, what to tell them or to how to help them?
I think there's some expectation that as they move, there will be pain. It shouldn't be like intractable pain, but I think, kind of setting the stage that, during therapy, especially in the beginning, it may be a bit uncomfortable, but assuming they can push through that, I think they'll benefit. I think if the pain is really just kind of rip roaring, screaming, they can't tolerate it. I think we do, we end up seeing a lot of those patients back because they can't tolerate physical therapy. I think it's a case by case basis, but we definitely see patients who just have what we refer to as intractable pain, and we have to figure out something else.
Thank you. Are there any recommendations for any specific supportive types of pillows for sleeping? Any type of neck pillow or
So I am a huge advocate of neutral alignment. So what that means is you shouldn't be sleeping on your belly, kind of hyperextended, putting a lot of pressure there. Similarly, you shouldn't be on like massive flexion. So the problem with some of these Tempur-Pedics, they're designed to give you neutral alignment, but depending on how heavy your head is, it's either going to kind of cause the pillow to sink all the way in. You might be hyperextended, or your head's not that heavy and you're kind of lying there flexed. So I think it is kind of a case by case basis. But you go to the store, you just try, kind of put your head, you can even, take it out, lie on the floor and be like, hey, when I'm lying here, am I pretty much neutral? And that's the best way, because when you start getting to those flexion extension moments, that's when you end up with the pain.
thank you. I think I'll probably know the answer to this, but would it be better to try other alternatives to surgery, before considering surgery, like chiropractic, PT, injections to relieve the pain?
Always, always, right? Like, not that surgery has to be a last option. And surgery, I have to say, for the neck is super successful. I don't lose a minute of sleep telling someone who I really think needs surgery on their neck to have surgery. I think they'll do that well. Having said that, like, if you don't need surgery, you don't need surgery. And so you certainly should be trying some of those non-operative things first.
Thank you. What is the recovery period for cervical surgery? How long will it take to be able to do things such as like cleaning?
So let's speak specifically about the neck. Like I said, these are not generally painful surgeries. I mean, you'll always have certain people who are, a bit more sensitive to pain, and so they may have pain kind of out of the range of what you consider normal. But for the majority of people with these conditions, people don't have a lot of neck pain from these operations. I'm telling you, it's the swallowing things, it's the hoarseness, it's those other issues are the things we see more commonly. Um, Especially for a single or two level procedure, usually in a soft collar, you could do most of what you want pretty early on. Um, at least I don't have an issue with that. Now, you start talking about, you're a police officer, you have a lot of kind of job requirements. Okay, your recovery might be different than somebody who, kind of sits at a desk and is, kind of, an administrative assistant or something like that. So it's certainly, patient by patient, case by case specific, but I think it would be faster than you think, probably.
Thank you. Another question from a PT. They have a patient that had foot drop. Imaging revealed no lumbar involvement, but there was a cervical disc herniation, no pain in the neck or arms, and a fusion was completed. No change in the foot drop. Was this assumed was this assumed the drop was caused by cervical myelopathy?
That's really hard to know. I so that I don't know what I would have done in my own practice in that setting. You don't want to leave someone with a foot drop, and if it were me, I certainly wouldn't want that. And if the lumbar spine is totally normal, presumably it's coming from somewhere. Generally I get an EMG in that setting to see like, hey, is this actually coming from the knee or something like that? All that workup's normal. You don't want to leave a patient suffering. I don't think that's unreasonable. Um, but I can't say I'm shocked that the foot drop didn't resolve. I mean, even times in the lower back where we're operating on patients with a foot drop with clear stenosis, I do have counsel them that that thing does not always resolve, even with an excellently performed surgery. So that's frustrating, but I understand it.
A nice compliment. Someone said, "You're the man. What an amazing doctor. Rothman is lucky to have you."
That's very nice. I love that
Uh,
person.
um, all right, I think we have time for a few more, if that's okay with you.
Perfect.
Okay. Is surgery risky if you have severe osteoporosis? This person said they had a surgeon tell them they would not do a fusion on them, but was open to surgical foraminal widening.
So that's a great
That's the
question. Yeah, that's a great question. I'm going to stick to it in the neck, but it's definitely different for the neck and lower back. So you have to understand what osteoporosis means is, let's just call it weakening of the bone. It's not really, it's some demineralization of the bone, but the bone is functionally weaker. And so the neck, you have to worry about, carrying the weight of your head. Your lower back, you're carrying the weight of your body. So I definitely personally have different guidelines for neck and lower back issues. I'm a little less concerned with the neck, but not concerned. And if I really think someone has really severe osteoporosis that wouldn't be able to hold an implant, meaning couldn't support the screws, couldn't support these spacers, it's not unreasonable to try to find an alternative solution. And in that setting, you can try a foraminotomy, which is where you go to the back of the neck. It's motion preserving, right? They're not fused. The outcomes may or may not be as good, kind of depending on the indication. But it's a reasonable option to save someone a bad complication, right? It's very frustrating when kind of the graft subsides and you lose some of that nice kind of relief you got initially. And that can happen with osteoporosis, unfortunately. I didn't mention it for the replacements, but osteoporosis is a contraindication, meaning you can't have a disc replacement with the osteoporosis because it's bad enough if the fusion settles, but there people are usually okay anyway. If the replacement settles, that's a big problem.
Okay, thank you. This person said they've had two epidurals in C2, C3, and they'll be having RFA to alleviate pain in the arm and neck. However, they were told that this would also help occipital neuralgia. The epidurals have not alleviated this, so how can RFA do this? Is different treatment needed?
It's hard to know. If there's a lot of arthritis at C23 and you had an RFA at C23, I could, make an argument that you might expect that there's some referred pain from the facet. And if you do an RFA at that level, it may improve. It's kind of a very specific question, so it's hard to know exactly, but I could see a world where that's possible.
Okay, thank you. Um, Thoughts on peptide injections with resolving nerve inflammation?
Great question. So I myself happen to love podcasts. And so even though in the medical literature, I wouldn't say peptides are nearly as big as kind of what you'll hear on podcasts and different internet forums, anecdotally, people say they work. I really have no idea, and I have no evidence, meaning I've tried to do my own due diligence and my own research in the spine literature. There are no good quality studies. That's not to say it doesn't work. That's just to say that if you said to me, hey, it's going to cost you $5,000 to get a peptide shot, I'd probably be like, no, thank you. If there was a way to get it, for free or relatively inexpensively, again, I think basically no downside. I just don't know whether it'll work. I know people talk about it all the time. I need to see the data before I make like a scientific decision, and I don't know of any yet.
Okay, thank you. There's a couple like really specific questions, so I do apologize if we did not get to those. Let me see if there's any kind of general question. All right, this one just came in. Is there any potential for PRP or hyaluronic acid injections to help neck pain and stenosis?
Good question. So, not that I know of hyaluronic acid. Hyaluronic acid is generally performed for joints. I don't know whether they're, again, I don't do injections, so I shouldn't definitely say no. But generally, that's done for like hip, not even hips, just knees, really, as far as I know. Maybe they do it into the disc itself nowadays. I can't imagine they're doing it in the cervical spine because it's a little bit risky to inject the disc because you're going around the spinal cord. PRP, I imagine, is the same thing, meaning I don't know whether you're referring to intradiscal PRP, where they put in the disc itself, or whether you're putting in the facets. What I do know, what is scientifically driven, is that all those modalities, hyaluronic acid, PRP, they're not reconstituting the disc. Even stem cells, I know of no data that, I mean, they may show these things, but to our understanding, and we have a lab at Rothman, so meaning we run a lot of these studies ourselves, they are massively anti-inflammatory. So you get a very nice kind of response because they're very strong anti-inflammatory medication, the same way like a steroid is. So I buy that. But I don't really think it's going to reconstitute the disc or kind of reverse arthritis. Maybe that's controversial, but that's that. I wouldn't say that that is kind of gold standard, widely accepted in the spine world.
All right, thanks, Dr. Kaye. Appreciate it. Very informative. Thank you for answering all those questions. We had like over 50 questions come in. You answered most of them. Again, we apologize if we did not answer your question. But Dr. Kaye, thank you so much. Thank you everyone for logging on tonight. A couple questions. We did record this. We will be sending it out to everyone who registered. So even if you weren't logged on tonight, you will be receiving this. And you all have my email. So if you are interested in making an appointment with Dr. Kaye or any of our other providers at Rothman, feel free to reach out to me directly. I'm happy to help facilitate that so you don't have to call and wait on hold. Um, any questions, please let me know. Dr. Kaye, thank you so much. Everything was great. Thanks everyone again for logging on. We apologize for the technical difficulties in the beginning, but hopefully you enjoyed tonight's webinar.
Thanks, everyone.
Have a great night. Thank
Good
you.
night.